let's go back in time. Let's take that individual patient, maybe 10, 15, 20 years prior to having the knee replacement. And I would love to hear, before we turned on the camera, we were talking a little bit about some of the research and the studies out there on arthroscopic surgery and some of the newer studies that are coming out. I'm going to let you take over from here. Tell us about some of the newer findings that are going on related to debridements and arthroscopic surgery.
Yeah, so as we sort of talked about, this is a little bit of a hot topic because it varies from patient to patient, it varies from surgeon to surgeon, and there's different sort of school of thoughts, and everybody has a good sort of, it's coming from a good place, and they just want to do what they think is right for the patient. So we're not condemning anything. We're just sort of presenting what the data shows. And so there was a study that came out from the British Journal. And there was a randomized control study. There was a meta-analysis. This is sort of like the highest grade studies looking at all the literature out there. And what a randomized control study is for folks listening in is essentially you are comparing side by side at the same time a group of patients who don't have the surgery or have what's called a sham surgery. I know it sounds scary to say that someone's performing sham surgery on you. However, it basically are performing some of the steps of the surgery, what a cleanup or debridement surgery is, but they don't actually do anything about it. They sort of run water and clean up that way, debride that way, but not so much with shavers and whatnot. And they compared to patients who actually did the shaving and the debridement and cleanup, and those are some of the questions. So basically what the surgeon is doing is taking a knee that's showing wear and tear and sort of taking away some of those free sort of fraying material that could potentially still be pinched by the top bone and the bottom bone as you walk, as you put weight on it. And this is what's causing pain. So if your meniscus, which is that little C-shaped structure inside the knee, with time gets beat up by the top bone and the bottom bone, starts causing these little tears of degeneration. That could be painful, right? Everything in our body has pain nerve endings. So it's painful. So what doctors or the surgeons are doing is they're sort of kind of cleaning up that edge, any of that fraying. If they see a chunk of the cartilage in your knee, they sort of shave that off a little bit so it's not sort of flapping in there. But that's about it. So they're not replacing, they're not repairing. You know, if you look at that study, they actually looked at the repair stuff. And I tell them all along, I say, look, if you had a completely pristine knee and you are, I don't know, 20s, 30s, 40s, you had an accident or something happened, twisted a knee, you were playing a sport, we get an MRI, beautiful looking cartilage, this meniscus has a huge tear in it, you are a surgical candidate. Studies have shown that not doing surgery, doing physical therapy, it's likely not going to help you long term because your knee was completely fine all along. This is an event, caused an injury to your meniscus, you go in there and you actually repair it, not so much debride it, you repair it, you actually put that piece back down and you suture it. Those guys do better, right? They get their sort of their life back. What we're talking about is this is now a degenerative knee. This is not an acute injury. This is now wear and tear over time. This is you basically kind of narrowing, getting closer and closer. The debridement just did not show any benefit, right? So these patients had all these surgeries and it just did not show any benefit compared to the ones who just had physical therapy, compared to the one that just used anti-inflammatories or injections or weight loss. Weight loss is, a huge topic and we can talk about for days, but all that pressure on the knees, every pound you take off is 4 pounds pressure to the knees. Those patients did much better than the cleanup surgery. So what my experience in my clinic with these patients is I always ask, did you have physical therapy? Did you have any injections? Did you try weight loss? Did you try bracing? Did you try surgery? And they say, the majority of them say, yes, I had cleanup surgery. When was it? Well, you just said 10, 15 years ago. And I get it. They're young, right? No surgeon wants to rush to, and I don't want to rush to replacement either. So, what I tell folks is that this is a very commonly performed operation, the cleanup surgery or the meniscal cleanup surgery. And it's just a coin toss. It's a flip of the coin. I'm sort of in a business of having these great outcomes with my patients. So when they come to me and I had a knee replacement, was for the right reason. They were at the right stage, severe arthritis, and they hit a home run. They were happy. This is exactly what they needed. So it's not an awkward conversation. Well, doc, you did surgery on me, you didn't help me. It can still happen with knee replacement. We can talk about it in a little bit. but the majority of folks, for the right reasons, are very happy with their knee replacements. I just haven't seen that with the cleanup surgery patients. They come to me and they said, I had 2 to 3 of these. How long did it help you? 3 to 6 months. Is the pain bad? Yes, right? We're not replacing anything. We're taking away stuff. We're leaving behind still a damaged knee. Now there's more space for the bones to come together because whatever was in between them, the cartilage or meniscus, you've shaved that off even more. And so if you're going to have one surgery, just have one surgery. I'm not saying right there and then, I'm saying down the road, but just have one surgery because there's cost to that. There's unnecessary risk. And now when you have your replacement, you're not at a higher risk of stiffness. You're not at a higher risk of infection because other instruments have been in the area and they can deposit dormant bugs. And now all of a sudden you sort of reflame all that. Every time I open these knees up for my knee replacement, there's a lot of scarring behind the kneecap. There's a lot of scarring behind the patella tendon. The little fat that we all have there is very scarred down, which makes the exposure hard and makes that tract of the patella harder. So these folks get stiffness afterwards. And so, and again, they're they see different surgeons and they offer this, and that's okay, right? They just want to try anything they can. They're miserable, they hurt, and I totally get it. They just need to know the risks. They just need to know that the outcomes, what they are. And if they still say, I'll take my chance, then that's fine. Do I have any patients of mine that tried that? Maybe 1 or 2, but I usually just stay away. And folks appreciate that. They say, well, that's honest. I'd much rather you tell me that, and I'll make the decision if I want it or not. But most folks sort of back out of it once I sort of lay it out that way.
And I can remember I was down in Florida when I first heard of the first study on this topic. So this would have been prior to 2006. I can't remember, maybe 2003, 4. And it just blew us away that, like, how can you say that having a knee scope or moving the floating pieces around in there isn't better? But, the data suggests that once you get past a certain phase, I mean, there really was no difference. And the people who had the sham surgery were so absolutely convinced because they felt so great. We've seen this procedure repeated in rotator cuff repairs where they were doing sham versus actual surgery and the outcomes were mixed. And so I have to wonder, though. I mean, I always go back to it's so easy to blame and vilify the surgeon, the physician, the physical therapist. But I wonder how much as well is the fact that I don't think it's always well explained to the patient on the purpose and the goal and what's happening. And so my understanding, too, is part of the gold standard of really understanding what's going on in the joint is to go in and scope it. Let's go in and see what's actually in there. We've got imaging information, but if, we've tried therapy, we've tried medication, we've tried the injections and all the other stuff, and we're still not getting the outcome, let's go in and see what we can see with our own 2 eyes. I want to share a quick story, and then I want to hit the next topic. My wife was a physical therapist. She was a high school, college athlete. She played soccer into adulthood. And before we were married, she had some floating cartilage around in her knee. She got the imaging. The imaging suggested some medial damage to the meniscus and the cartilage that covers the bone. I wasn't her husband at the time. This is an interesting story. So I was able to sit in on the surgery. We were friends with the surgeon, acquaintances with the surgeon. She got a spinal so that she was awake. I was awake. The surgeon's there with us and we're looking around. And everything that the MRI showed as problematic showed totally clean. And we were dumbfounded. We were like, well, what are we supposed to do now? And I genuinely believe it was one of those things where it would have been really easy to close it up, move her, into rehab. But as we kept looking and discussing, we're like, well, should we do microfracture? And he did shave the underside of the patella. She kept saying, I know the MRI is medial signs, but all my pain is lateral posterior. And once he got into that area, a big chunk of cartilage, I think it was like 30 millimeters, floated out that nobody had seen. So there it was. He pulled it out. We talked about cleaning up the edges. At that time, microfracture would have meant non-weight bearing. We were going to Ireland in like 3 weeks. We're like, we can't do that right now. So close it up, did some physical therapy, went on our trip. But there's still so much context and so much we don't understand. And every human body is just so different. Like you mentioned, I would never fault somebody for having the procedure. You're looking for a solution, and I think it's relatively low risk. I mean, that's
Yeah.
more your world than mine. But that being said, I know in my clinic, I see a lot of patients who have a scope. They think it's a repair. They think it's a fix. And I just try to explain it's not a fix. It's not a repair. They're cleaning the edges. They're removing the debris that's floating around in there, but you still have the rawness on the ends of the bone. You still have the damage that's in there. There's just less debris in there now. Is that accurate way to describe it?
Right. It's sort of, the tire analogy. There's like a wear and tear, and all of a sudden a nail goes in there. So instead of replacing the whole tire, you do a little patch, but what's underneath that patch is still a damaged tire. And
Right.
so this is just a Band-Aid. This is temporary. These folks truly do get relief from this. When you say 3 to 6 months, it helped me, is because they do get relief from it. And some of that is maybe what they cleaned up, and some of that is just the endorphin. Some of that is just you basically causing damage to the knee with the instruments. Right. And so all that sort of blood rushes there to repair. So all those sort of same thing with stem cell injections or the PRP injections. You're sort of bringing a lot of factors inside your knee that if there's any damage somewhere, they do patch things up. They do make patients feel better. And so they do get relief from it. And it's just that it's not long-term. Is the one that I've seen long-term is folks, again, otherwise a very pristine knee, a very unique injury with a particular pattern that the surgeon went in there and repaired, truly repaired, meaning you put together sutures and brought things together. But otherwise, these debridements, these degenerations, the narrowing, all that, sometimes, in the beginning of it, I sort of understand it, but as it kind of gets further and further, it does pain me a little bit to see some of those x-rays being scoped when it's just bone-on-bone arthritis, really, or get an MRI. I don't need an MRI to tell me what you're going to find underneath. It's bone-on-bone arthritis on the x-ray. So I'm a very minimalist. I'm a very conservative. I'm sort of evidence-based. I think it's best for patients because, I personally don't like to have those awkward conversations with them. I want to be able to say whatever I did for you was the right thing for you and you're actually happy. So, but to each their own. Obviously, we talked about patients are in a very difficult situation. And so that's just a personal conversation with their surgeon. But that's just what data show. And as long as folks know, they can make their own decision.
And so with that, let's jump from the frying pan into the fire and let's talk about persistent pain. Pain that's, going on longer than somebody would expect. I know every patient that walks in my door who's had a total knee replacement, as you kind of mentioned, they had it to resolve a pain issue. And now 3 months, 6 months, 12 months down the road, they have a different pain issue. They've traded one pain for another.